Okay, so we're going to talk about basically bronchial sampling, bronchial fluids, and a little bit on body fluids. And when we get a specimen in the lab from the upper airways and from the lung, these bronchial washes, in cytology we get bronchial brushes, and we also rarely get bronchoalveolar lavages, and even I had to understand the difference between a lavage and a wash. In any event, these are some of the reasons why the pulmonologists do these procedures. At Emerson, the most common is they're looking for malignancy and infections. And then sometimes there's an indication. This is ILD is interstitial lung disease, which is essentially non-infectious inflammatory diseases of the lung. They're like, this is just a broad category. It's an umbrella term that is used to describe a whole host of lung diseases.
Look at the big guns now.
These are a whole host of lung diseases are somewhat rare, but in the lab we can help sort of tell the clinicians which specific lung diseases under this category they should be thinking about. Let's see. Okay, so this is how the procedure is done. This is Dr. Barkin, and he's got his bronchoscope, and the scope advances down the trachea into the main stem bronchi and into the some of the smaller secondary and tertiary bronchi. It does not sample, right? You can't stick a bronchoscope, which measures like 3 or 4 millimeters, down into the alveolus. These are much more terminal in the airways. Here's our lung. Here's Dr. Barkin can get his scope probably down to around here, and then this is the alveoli. So when they're doing a wash, they're interested in what fluid lines is in the alveolus. This is the scope just showing sort of higher magnification. They can use these to biopsy lesions in the, this is inside the lung now. And this is what it looks like. This is an image taken from the inside of a bronchus. This is normal. Sometimes he'll see tumors in here, and he'll take a brush. I think I have that's a brush. It looks like what are they called?
Mascara.
Mascara brush. Exactly.
Thank you, Maura.
So they'll roll that brush over the lesion and they'll send it to cytology. Okay, so just getting back to what I was talking about, bronchoalveolar lavages. This is a relatively older technique. Like I said, they were sort of trying to figure out what are the inflammatory cells that are in the airways, and then they used the different types of inflammatory cells, if it was like lymphocyte predominant or eosinophil predominant, to help them sort of narrow their differential. This is not entirely specific. If you see a lot of eosinophils, that could lead them down a certain path. There are certain things called eosinophilic pneumonias where the lung is loaded with EOs. So I think we could be helpful in that case. I mean, we can all identify EOs. So if you see a lavage or a wash with a ton of EOs, we're actually helping them. If we see like a ton of lymphocytes, that's not normal either. And that'll also narrow down their differential. So, I mean, it is somewhat helpful, but we're not the be-all and end-all of these diseases. Not everything hinges around us in hematology. We don't always have the answers, and a lot of these diseases are defined by their clinical and pathologic and radiographic findings. So we give them the information that we can, and then they've got to put it together with like high-resolution CT scans and the occupational history. There are a whole host of diseases that people get due to what, you know, beryllium exposure and asbestos exposure, and we're not going to make those diagnoses. Okay, there's, like I said, eosinophilic pneumonias we can help them out with, and so we have our role. Don't feel like you have to come up with a diagnosis. Okay, this is basically what I was talking about. This is the alveoli. This is the fluid that they're sampling in a bronchoalveolar lavage. Okay, now let's get into some cell identification. Now this is a histology slide. These are the cells that line the airways. Okay, these are the airways. The bronchi are the airways, and then you know the alveoli are terminal or distal to the bronchi. So the airways are more proximal, and they're lined by these columnar cells. They're tall columnar cells. Each one of these is a cell. And you can see that it has this lining of microvilli. This is the alveolus. It's not lined by these tall cells with microvilli. It's lined by flat cells. This is not the best cartoon, but it's lined by flat cells. You will rarely see them in bronchial specimens. But inside the alveolus, this is where you could find lymphocytes, you could find a lot of eosinophils. Most commonly, you'll find macrophages. I'll get into what those look like, how to identify them. But macrophages, they're really plentiful, and patients who smoke will have a lot of macrophages in their alveoli. Okay, this everyone should be able to identify. This is a unique appearing cell. It looks like, I like to call it like a Bart Simpson type of cell with the hair. These are the microvilli. It's got this sort of bar at the base. This is like a terminal bar where the microvilli insert into. The nucleus is at the base, and it's sort of tall and slender, and sometimes you can see, just at the base, you can see a little tuft of cytoplasm. So these are pretty distinctive. This is a Guim cystine. Not as easy to see in this slide, but you can still make out that there are some cilia here. Again, it's a columnar epithelial cell. Nothing else looks like this. Here's another one. This one is more rounded than the others, as opposed to being columnar, but it's still got cilia. Okay, these are probably going to be the most common cells that you see in a lavage specimen. And again, these are the macrophages. They have more cytoplasm compared to the bronchial epithelial cells. They don't have cilia. They're sort of rounded, abundant cytoplasm, which is sort of vacuolated. You can see some vacuoles here. So that's going to be the most common cell that you see. Macrophages, they're called tissue macrophages sometimes. When they're in the blood, these are essentially from the same cell line as monocytes. They're cousins, essentially. This everyone should be able to identify. These are also pretty distinctive. These are squamous epithelial cells that come from the oropharynx. You shouldn't see those in the alveoli, and it suggests that there's contaminant from the upper airway. They have a small centrally placed dark nucleus and a lot of cytoplasm. Oh, cilicytophoria. I've been called into the lab a couple of times to go over this. It's an exciting finding. I don't know if everyone's seen it. Where is it? Is it here? Oh, maybe it's here. Oh, you know what? They put it on here. Okay, so here's a YouTube video of cilicytophoria. Sometimes people mistake them for parasites. This is obviously a wet prep, and it's a video. And you can see these are the cilia that are sort of beating back and forth. This is a group of bronchial epithelial cells, and they could be mistaken for a parasite, but they're just those respiratory epithelial cells. Bronchial epithelial cells. Okay. Okay, Jen, do you want to talk about this stuff?
Yeah, sure.
Or we can,
So
yeah.
we just wanted to include some information for you guys in the lab about the procedural differences from a bronchial wash versus a regular body fluid. So we made its own order code, and so after you order that, you can pick bronchial wash or lavage when you're doing your result entry. And one of the major differences is that you're now going to be counting the epithelial cells. Those numbers aren't going to be included in the leukocyte differential because of the way that we set up the result entry screen in Meditech, but it's going to be counted so that doctors have that information available to help them determine what kind of specimen they collected, whether it was a good collection or not. And the Meditech result entry, usually we enter in like M or whatever your regular mnemonic is when you're doing a regular diff. In that field, and I've printed out screenshots for you guys to take with you, you're going to enter bronch fluid to get to that diff calculator. We're also going to be counting 200 white cells instead of 100, which is different. And you're going to spin your slides down for a longer period of time and at a lower speed if you think that you need to. Mars put up a cheat sheet in the cabinet over the cytospin that has a great, if view of how many cells and the speeds that you can use. And this is what the result entry screen is going to look like, just so you know. And again, I printed out copies for you guys to take with you. One thing to note is on the screen that has the results entered into it, you can see that there's 200 white cells, but that the total cells counted is 214%. That's okay. You're going to count until you get 200 white cells. And then this is included in the procedure. Basically, it's just something that you should be aware of. The reason why you're counting the epithelial cells is to help them determine if they have a satisfactory specimen. And bronchial washes and lavages each have a different combination of cells that make them satisfactory or not. And this whole language is in the procedure, so you can read more about it.
Very few of the specimens that we're going to get are actually going to be called bronchoalveolar lavage specimens, right?
Yeah, you said like 1 or 2 a year.
Yeah.
Most of what we get are washes.
Okay, body fluid update. So just to review the different types of body fluids, the main ones that I'm going to talk about are, well, I'm not going to talk about pericardial, but the pericardial, the pleural, and the ascites, or the abdominal cavity fluid. So this is a cross-section of the abdominal cavity with the liver, the kidneys, the spleen, and the stomach. And this space over here, bounded by this white line, is the abdominal cavity. That's where the ascites fluid is that they're going to be tapping. And this white line represents the mesothelial lining. So all the body cavities in the pericardium, in the abdominal cavity, and surrounding the lung are surrounded by mesothelial cells. So we have to know sort of how to identify mesothelial cells. This is the lung. Before, with the bronchial washes and the lavages, we were inside the lung. These specimens with body fluids, the pleural fluid is obviously on the outside of the lung. So you're never going to see bronchial epithelial cells in a pleural fluid, because the bronchial epithelial cells are inside the trachea and the bronchi, whereas the pleural fluid comes from the outside, so we'd expect to see mesothelial cells. Okay, so let's review what mesothelial cells look like. They sort of look like macrophages. They have, this isn't the best picture, I think there are better ones. This is a good cartoon to start off with. Centrally placed, and it could sometimes be eccentrically placed nucleus, relatively abundant cytoplasm, and the key to identifying mesothelial cells is that they have a two-tone cytoplasm. So here it shows that there's a sort of an inner darker endoplasm. I mean, these aren't typical terms, and a peripheral light ectoplasm. Sometimes it's the opposite. But here you can see that this rim is sort of lighter than the internal cytoplasm. That's a clue, and here this is more distinctive. The vacuoles are on the outside, and then the cytoplasm around the nucleus is darker in this particular case. It'll vary from stain to stain, but just identifying it as a two-tone cytoplasm will give you a hint or a clue that it's a mesothelial cell. Here you can see good two-tone cytoplasm. Again, they're sort of rounded cells. Here's good two-tone cytoplasm. The nucleus usually does not touch the periphery of the cell membrane. Here it is, but typically it just goes next to, but not up against the cytoplasm, up against the cell membrane rather. Oh, this is a good two-tone cytoplasm over here. If you don't know what it looks like, you can always Google it. This is another clue about mesothelial cells. These are called mesothelial windows, where the cells look like they're holding hands with this clear space between them. That's another clue that you're dealing with mesothelial cells. It can be difficult to distinguish mesos from macrophages, but here you can see sort of smaller vacuoles in these cells. This is probably a macrophage in here too. It might be a meso, I'm not 100% sure. Some people have asked about mesothelioma. These specimens are typically more cellular. The cells look a bit more atypical, but it still has a look similar to normal looking mesothelial cells. Again, it's very difficult to identify or to diagnose mesothelioma in a body fluid. Again, the key thing is that it's cellular. You have three-dimensional groups of mesothelial cells. And again, this is a cross-section of the lung. This is all normal lung. The mesothelial cells, as I said earlier, are on the outside of the lung. This thick rind of white stuff is actually mesothelioma that's encasing the lung. So they'll see this on, they'll put together what we're seeing in cytology or hematology, telling them that they have a cellular specimen with a lot of mesos. They'll put it together, and then there are other things that we can do in cytology in terms of special stains to identify the cells as mesothelial cells. I think our role in hematology is just to say, oh, look, there are a lot of mesos. It's a cellular specimen. Some of the cells look funny, and just send it on to cytology, and we can do more studies. Then identifying adenocarcinoma in body fluids and comparing them to reactive mesothelial cells. Here we have a group of reactive mesothelial cells. Again, you can see sort of vacuoles more on the periphery of the cell. These clusters are more two-dimensional. And then adenocarcinoma, you have more sort of three-dimensional clusters. There's some variability in the nuclear size. Here's some larger nuclei. And the nucleus is pressed right up against the cell membrane. In mesothelial cells, remember I said the nucleus is not pressed up. I mean, this is not it's easier said than done. I mean, these can be difficult to diagnose if they're a relatively low-grade malignancy. But the one thing to be aware of is a two-cell population. So you'll see what looks like one population of cells which represents mesos, and then another more atypical population of cells which represents adenocarcinoma. Again, all these slides should be sent to cytology. This is just a high power three-dimensional cluster, a lot of nuclear variability, really enlarged dark nuclei. That's adenocarcinoma.
So in the lab part of this, the ADVIA has been approved to be used for processing body fluids, so pleural fluid, pericardial, peritoneal, as long as there's no clots in it. If you get an EDTA tube, use that first. We've also decided that it would be helpful for you guys to have our right stain slides of any body fluids that have cytology orders on them. So just make 2 slides in addition to what you have, cover slip them. I guess night shift you guys can leave them for the day shift to get cover slipped. And then we can bring them down to Lee for them to review with their other slides. We're not going to count mesothelial cells anymore as a part of the leukocyte differential, which Dr. Sherman has said really isn't clinically significant, and that we really should be just doing a 5-part diff. And then also, cytology has talked to us about a lot of times they don't have enough spinal fluid or bronchial wash fluid to make their cell blocks. So if we have any leftover specimen, we're going to start to put it in their refrigerator. So those are just those are updates to the regular body fluid procedure. That's just an extra slide.
Okay, I forgot to delete that. Are there any questions?